Welcome to Vet Neurojar, the podcast dedicated to exploring the fascinating intersection of neurology and veterinary medicine. I am your host, and today we are diving deep into the complex world of inflammatory myopathies in horses, specifically focusing on Myosin Heavy Chain Myopathy, or MYHM, infarctive purpura hemorrhagica, and other immune-mediated muscle disorders. These conditions represent a significant challenge for equine veterinarians, and understanding their intricacies is crucial for effective diagnosis and management. Let us begin by setting the stage. Inflammatory myopathies in horses are a varied group of muscle disorders characterized by the infiltration of leukocytes, or white blood cells, into skeletal muscle and around blood vessels. This is a key feature that distinguishes these conditions from exertional myopathies, where macrophage infiltration of myofibers is more common. The types of leukocytes involved, whether they are neutrophils, eosinophils, or lymphocytes, often depend on the underlying cause of the inflammation. What makes these myopathies particularly challenging is the extensive overlap between those with apparent infectious components and those that are immune-mediated. This means that teasing apart the exact cause and developing targeted treatment strategies can be difficult. Our primary focus today is on Myosin Heavy Chain Myopathy, or MYHM, a condition that has garnered significant attention in recent years. MYHM is a codominantly inherited myopathy primarily affecting quarter horse-related breeds. What is particularly interesting about MYHM is its pleiotropy, meaning that a single genetic variant can result in multiple different clinical presentations. These include immune-mediated myositis, calciphylaxis, and non-exertional rhabdomyolysis. To truly understand MYHM, we need to delve into its genetic basis. The root cause of MYHM is a missense variant, specifically E321G, in the Myosin Heavy Chain 1, or MYH1 gene. This genetic alteration leads to an amino acid change within the myosin type 2X heavy chain, substituting a negatively charged glutamic acid with a nonpolar glycine. This seemingly small change has significant consequences, as it is predicted to markedly reduce the protein stability of myosin. The inheritance pattern of MYHM is autosomal codominant with variable penetrance. This means that a single copy of the affected allele is sufficient to cause disease, and horses with two copies are generally more severely affected. Studies have shown that around 80% of homozygous horses, those with two copies of the disease allele, and 20% of heterozygous horses, those with only one copy, will develop clinical signs of MYHM. Furthermore, homozygous horses are more likely to experience frequent recurrence of clinical signs compared to their heterozygous counterparts. Given its genetic underpinnings, it is important to consider the prevalence of the MYH1 variant within the equine population. Estimates suggest that around 1.6% of the general equine population carries the MYH1 variant. However, clinical disease is primarily reported in quarter horse-related breeds. Within the quarter horse population, the prevalence of the MYH1 variant is considerably higher, ranging from 7 to 8%. Interestingly, certain performance subgroups within the quarter horse breed, such as reining, working cow, and halter horses, exhibit a higher allele frequency. While the variant is less common in barrel racing and racing quarter horses in the United States, it has been identified in Brazilian quarter horse populations used for barrel racing and racing. It is also worth noting that while the MYH1 variant was initially documented in quarter horse and related breeds, it has recently been reported in an unphenotyped heterozygous Belgian horse. Additionally, horses carrying the MYH1 variant may also possess causative variants for other muscle diseases, including polysaccharide storage myopathy type 1, glycogen branching enzyme deficiency, malignant hyperthermia, and hyperkalemic periodic paralysis. This highlights the potential for complex interactions between different genetic factors in the development of muscle disorders. Now that we have a solid understanding of the genetic basis and prevalence of MYHM, let us turn our attention to the triggers that can lead to the development of clinical signs. Interestingly, a significant proportion of horses with MYHM, between 25 and 46%, have a history of environmental triggers. These triggers can include respiratory diseases such as Streptococcus equi or Streptococcus equi zoepidemicus, concurrent Corynebacterium pseudotuberculosis infection, Anaplasma phagocytophilum infection, or even vaccination with influenza, equine herpes virus 4, or Streptococcus equi. In fact, a study of hospitalized cases found that 78% of severely affected horses had a history that included these types of triggers. There was even a report of a quarter-horse filly experiencing concurrent active Streptococcus equi infection, MYHM, immune-mediated myositis, and purpura hemorrhagica. However, it is important to remember that in over half of MYHM cases, an inciting agent for the development of clinical signs is not identified. The three primary clinical phenotypes of MYHM, as we mentioned earlier, are immune-mediated myositis, calciphylaxis, and non-exertional rhabdomyolysis, and some overlap can occur between these presentations. Let us start with Myosin Heavy Chain Myopathy, Immune-Mediated Myositis, or IMM. Horses with this form of MYHM typically have a biphasic age range, with most cases occurring in horses 8 years of age or younger, or 17 years of age or older. There is no apparent sex predilection. The primary clinical sign of MYHM IMM is profound and rapid atrophy of the epaxial and gluteal muscles. This muscle wasting can be quite severe, with some horses losing up to 40% of their affected muscle mass within 48 hours, and the atrophy can persist for months. As a result of this muscle loss, affected horses may become weak and experience frequent episodes of recumbency. A concurrent fever is present in approximately 44% of horses with the MYHM form of IMM. Homozygous horses, those with 2 copies of the MYH1 variant, are more likely to develop rapid-onset muscle atrophy compared to heterozygous horses. During the acute phase of muscle atrophy, serum creatine kinase, or CK, and aspartate transaminase, or AST, levels are moderately to severely elevated. However, during chronic atrophy, these enzyme activities may return to normal. Unless there is a concurrent infection, hematology is usually within normal limits. Diagnosing MYHM IMM relies on identifying the MYH1 variant in quarter-horse-related breeds exhibiting severe muscle atrophy. Prior to the availability of a genetic test, diagnosis was primarily based on true-cut samples fixed in formalin or fresh frozen Bergstrom needle biopsies of the epaxial and/or gluteal muscles. Horses with the acute IMM form of MYHM typically show lymphocyte infiltration of type 2X myofibers without glycogen depletion, as well as lymphocytic cuffing of small blood vessels. In contrast, horses in the chronic stages of IMM, where atrophy has been present for several weeks, often exhibit nonspecific myogenic atrophy and regeneration on muscle biopsy, without the characteristic lymphocytic inflammation. It is worth noting that the semimembranosus and semitendinosus muscles are often only mildly affected or appear normal. The pathophysiology of MYHM IMM shares similarities with human and canine immune-mediated myopathies. This includes restriction to specific muscle groups, a predominance of CD41 T cells in affected muscles, and major histocompatibility class 1 and 2 expression on myofibers. In fact, lymphocyte populations in IMM are predominantly CD41 T cells in 48% of cases and CD81 T cells in 28% of cases. Other cell types present include CD201B cells and macrophages. Immunoglobulin G staining of the sarcolemma is not a consistent feature of IMM. During the acute phase of MYHM IMM, major histocompatibility type I and/or 2 staining is present on scattered myofibers in 81% and 71% of horses, respectively. Major histocompatibility complex class 1 and 2 are not normally detectable on healthy mature myofibers, and class 2 expression is highly specific for immune-mediated myopathies in humans. While major histocompatibility complex expression develops in the presence of cytokines, the precise reason for its upregulation on the sarcolemma in these horses remains incompletely understood. The current working hypothesis for the development of MYHM IMM suggests that damage to myofibers, perhaps through vaccination or trauma, leads to the release of the altered myosin heavy chain form and activation of the innate immune response directed toward type 2X myofibers. Horses with the MYHM variant and signs of IMM tend to have fewer type 2X myofibers compared to controls, likely due to the destruction of these fibers. It is thought that the loss of hydrogen bonds in the altered myosin heavy chain protein leads to a myosin conformation change and activation of toll-like receptors in autoimmunity. The idea is supported by the fact that cardiac myosin fragments in humans can activate toll-like receptors, which are important for driving reactivity to self-epitopes. It is also hypothesized that the adaptive immune response may be triggered by shared epitopes between bacteria, such as the Streptococcus M protein and myosin, a phenomenon seen in some forms of human immune-mediated myocarditis. When it comes to treating MYHM, IMM, anti-inflammatory doses of corticosteroids tapered over 1 month are the mainstay. For example, intravenous dexamethasone at 0.05 to 0.07 milligrams per kilogram per day for 3 days, followed by oral prednisolone at 1 milligram per kilogram per day for 7 to 10 days, tapered by 100 milligrams per week, if serum CK remains stable. Early corticosteroid treatment can reduce potential atrophy and shorten the time required for muscle mass recovery. It is also important to treat any concurrent infection and provide supportive care, especially for horses with frequent episodes of recumbency. Muscle mass typically recovers over a period of weeks to months, depending on the initial severity of the atrophy. While horses can make full recoveries, recurrence is observed in 50% of MYHM homozygous horses, who also tend to experience more frequent and severe episodes and are less likely to return to normal muscle mass. Next, we will discuss Myosin Heavy Chain Myopathy and calciphylaxis. Calciphylaxis, also known as systemic calcinosis, can occur in horses homozygous or heterozygous for the MYH1 variant, often in those less than 9 years of age who are also exhibiting clinical signs of IMM. In these horses, calcification of muscle fibers and multiple other organs develops, and this condition is frequently fatal. Common clinical signs include malaise, mild fever, stiffness, muscle atrophy, and mild ventral edema. Other signs that have been reported include polyuria, polydipsia, and paroxysmal multiform ventricular tachycardia. The disease can progress rapidly due to multiple organ failure, potentially including respiratory distress, colic, and laminitis. Approximately half of reported cases have a history of recent infection, including Streptococcus equi or Actinobacillus equili, Anaplasma phagocytophilum, Salmonella, a reaction to an immune stimulant, or having been treated for IMM prior to the onset of calciphylaxis. Diagnosing calciphylaxis involves genetic testing for the MYHM variant, as well as identifying the pathognomonic biochemical finding of hyperphosphatemia. Specifically, the product of total calcium concentrations in milligrams per deciliter multiplied by phosphorus concentrations greater than 65 milligrams per deciliter is a key indicator. Other biochemical findings related to the organs affected by calcification can include azotemia, hypoalbuminemia, elevated cardiac troponin I, and severely increased CK and AST activities. Hematology typically reveals leukocytosis with neutrophilia and hyperfibrinogenemia. Notably, some cases of Streptococcus equi rhabdomyolysis have also shown elevated calcium phosphorus products, suggesting a potential overlap between MYHM non-exertional rhabdomyolysis secondary to Streptococcus equi and calciphylaxis. Gluteal muscle biopsies in horses with calciphylaxis showed diffuse anguloid atrophy, centrally located myonuclei, and scattered myofibers with acute necrosis and severe dystrophic calcification. Some horses exhibit marked macrophage infiltration of myofibers, multinucleated giant cells, and mononuclear vasculitis. Findings tend to be milder in the semimembranosus muscle. Necropsy findings include pallor of multiple organs, including skeletal muscle, kidneys, heart, and lungs. Dystrophic calcification is frequently present in several muscles, and other tissues may exhibit varying degrees of calcification, including the renal glomeruli, tubules and or collecting ducts, the aorta, aortic sinus endothelium, and surrounding connective tissue, and in the lungs, the primary bronchioles, alveoli, bronchiolar muscle, cartilage, and alveolar walls. Less frequently, there may be necrosis of the renal tubules, coagulative necrosis of the renal cortex and medulla, thrombosis of vessels, and renal interstitial infiltration with macrophages, lymphocytes, and plasma cells. The pathophysiology of calciphylaxis is thought to have an immune-mediated component related to the MYHM variant. During inflammation, cytokines such as tumor necrosis factor alpha and interleukin-6 can lead to enhanced bone resorption secondary to activation of receptor activator of nuclear factor kappa B, or RANK. The RANK ligand RANK signaling pathway receptor activator is important for regulation of multinucleated osteoclast formation, activation, and survival as part of normal bone remodeling. This can lead to hyperphosphatemia and dystrophic calcification due to deposition of calcium phosphate secondary to blood phosphate supersaturation. This process promotes conversion of smooth muscle fibers into osteogenic cell types and causes increased parathyroid hormone secretion and reduced renal production of 1,25-dihydroxyvitamin D levels. It is possible that recent or concurrent diseases present in horses that develop calciphylaxis trigger the inflammation that leads to the development of hyperphosphatemia and dystrophic calcification. While other causes of calciphylaxis in people include end-stage renal failure and vitamin D toxicosis, these are less likely in MYHM with calciphylaxis. Most horses with calciphylaxis were healthy prior to disease onset, and horses with chronic renal failure typically develop hypophosphatemia, in contrast to the hyperphosphatemia seen in humans. Additionally, compared to calciphylaxis cases, horses with vitamin D toxicosis have hypercalcemia and gastrointestinal hemorrhage. Treatment for calciphylaxis is similar to that for horses with MYHM, IMM, and includes supportive care with fluid therapy and appropriate antimicrobial therapy. Corticosteroid therapy is controversial, as there are concerns in human medicine about worsening bone resorption that could exacerbate the hyperphosphatemia. Unfortunately, the prognosis for calciphylaxis is generally grave, with only one reported case of an affected horse surviving. This horse was treated with dexamethasone, aluminum hydroxide, and slow administration of intravenous sodium thiosulfate to combat tissue calcification. Finally, we will consider Myosin Heavy Chain Myopathy non-exertional rhabdomyolysis. As the name suggests, MYHM horses can exhibit rhabdomyolysis that is not triggered by exercise. The MYH1 variant is a common cause of non-exertional rhabdomyolysis in quarter horse-related breeds. Overall, 67% of quarter horses with non-exertional rhabdomyolysis have at least one MYHM allele, compared to just 5% of the general quarter horse population. Affected horses are typically young, may be febrile, have firm epaxial and hindquarter muscles, and show marked signs of pain, stiffness, and myoglobinuria, with many horses rapidly progressing to recumbency. Sadly, these horses frequently die or require euthanasia due to pain and inability to stand within 24 to 48 hours of becoming recumbent. A recent Streptococcus equi or influenza rhinopneumonitis vaccination, or concurrent Streptococcus equi infection, precedes clinical signs in 40% of cases. MYHM non-exertional rhabdomyolysis shares many similarities with the previously named Streptococcus equi associated myopathy, with known cases having the MYH1 variant. Thus, Streptococcus equi myopathy is likely a subtype of MYHM non-exertional rhabdomyolysis. Diagnosing MYHM non-exertional rhabdomyolysis involves identifying the MYH1 variant in quarter horse-related breeds with clinical signs of non-exertional rhabdomyolysis. Gluteal muscle biopsies show myofiber necrosis with macrophage infiltration and glycogen depletion in 30% of muscle fibers. Less than 18% of cases exhibit myofiber lymphocytic infiltrates. Serum CK levels are markedly elevated, often exceeding 100,000 units per liter, and AST levels are also increased. Horses with concurrent Streptococcus equi infection typically have marked neutrophilia and hyperfibrinogenemia, guttural pouch empyema, and may be culture or polymerase chain reaction positive for Streptococcus equi. The Streptococcus equi M protein titer is positive in some cases. The pathophysiology of MYHM non-exertional rhabdomyolysis is thought to differ from the immune-mediated forms of MYHM. The lack of myofiber lymphocytic infiltration suggests that rhabdomyolysis may not be immune-mediated in these cases. Instead, it is believed to occur due to readily induced and persistent calcium activation of actin-myosin interaction from a hypercontractile phenotype, similar to the hypercontraction seen in horses with malignant hyperthermia. The severity and rapid deterioration of horses with concurrent Streptococcus equi infection is reminiscent of streptococcal toxic shock syndrome in humans, which is related to streptococcal superantigens. Superantigens can simultaneously bind major histocompatibility class II and T cell receptors, leading to massive T cell and antigen-presenting cell activation, causing massive cytokine release and toxic shock. Alternatively, infiltration of skeletal muscle by Streptococcus equi and release of streptococcal proteases could lead to myodegeneration. The identification of remnants of Streptococcus equi bacteria in the muscle of affected horses supports this idea. It is also possible that the immune response to the Streptococcus equi-M protein attacks muscle fibers due to similarities between the Streptococcus equi-M protein and myosin. Early diagnosis and prompt treatment are critical for managing MYHM non-exertional rhabdomyolysis. Treatment includes dantrolene, administered orally 3 times daily until serum CK activity has markedly declined. Intravenous or oral fluid therapy may be necessary to protect the kidneys due to the severity of the myoglobinuria. If bacterial infection is suspected, appropriate antimicrobials should be used. Corticosteroids may be indicated depending on the severity of concurrent infectious disease. Constant rate infusions of lidocaine or ditomidine or butorphanol can be helpful for pain management. Prolonged recumbency can be life-threatening due to compressive myopathy or neuropathy, pressure necrosis, reduced gastrointestinal motility, and difficulty urinating. While treated horses can recover, 35% develop acute muscle atrophy similar to that seen in MYHM IMM cases, requiring corticosteroid therapy. Beyond these specific conditions, it is important to remember that there are also uncharacterized immune-mediated muscular disorders that do not fit neatly into the MYHM framework. Notably, some horses diagnosed with IMM via muscle biopsy do not carry the MYH1 variant. These horses may have a non-MYHM inflammatory myositis, but distinguishing between immune-mediated myopathies and inflammatory myopathies secondary to an infectious agent can be challenging. Inflammatory myositis, or IMM, has also been reported in other breeds beyond quarter horses, such as ponies, thoroughbreds, Anglo-Arabians, Percherons, and warmbloods. These cases often involve concurrent infection or recent vaccination, but the underlying cause of IMM remains unknown. In addition to MYHM and uncharacterized IMM, other infectious inflammatory myopathies can affect horses. Sarcocystis fayeri, Sarcocystis bertrami, and Sarcocystis equicanes are common protozoa identified in horse muscle. While sarcocysts in the muscle are often incidental findings, some horses develop clinical signs, including gluteal, epaxial, and quadriceps muscle atrophy, as well as nonspecific signs like malaise, muscle fasciculations, anorexia, and weakness. Diagnosis is based on muscle biopsy and identification of sarcocysts with concurrent infiltration of lymphocytes, macrophages, and sometimes eosinophils. Successful treatment has included various antimicrobial and antiprotozoal medications. Pyroplasmosis, caused by Theileria equi and Babesia cabali, is another infectious disease that can lead to inflammatory myopathy. Horses with chronic pyroplasmosis may develop mild to severe muscle atrophy, and muscle biopsies often reveal lymphocytes and lymphocyte perivascular cuffing, along with mild major histocompatibility class 1 or 2 staining. Given the complexities of these conditions, preventing Myosin Heavy Chain Myopathy episodes is a significant concern for horse owners and veterinarians. The primary focus should be on minimizing exposure to infectious agents, avoiding immunostimulants, and carefully considering vaccination strategies. For MYHM horses that develop clinical signs after vaccination, it may be helpful to split up vaccines and use the minimum number necessary in subsequent years, spacing them out by 4 to 6 weeks to identify potential culprits. If muscle damage or atrophy is triggered, a discussion about the risks and benefits of that specific vaccine is warranted. Because influenza is a common trigger of MYHM, it should be avoided or an intranasal formulation used. Early administration of prednisolone is recommended if atrophy is observed after vaccination. Finally, to avoid producing horses most likely to develop a myopathy, breeding homozygous horses or mating MYH1 heterozygous horses with heterozygotes is not recommended. Finally, let's discuss infarctive purpura hemorrhagica. Most horses with purpura hemorrhagica have a history of Streptococcus equi infection or vaccination, although infections with other bacteria and viruses have also been reported. In IPH, a severe vasculitis develops, leading to infarction of muscles and potentially other organs. While any breed can be affected, quarter horses are overrepresented, with most cases occurring in horses aged 10 years or younger. Affected horses develop focal firm and painful swellings in muscles that are compressed during recumbency, such as the pectoral, hind limb adductor, and gaskin muscles. They may also exhibit stiffness, lameness, depression, petechiation, and limb edema. As multiple organs become infarcted, oral ulcerations, colic, laminitis, and hemorrhagic gastric reflux can arise. Diagnosis of IPH involves identifying marked elevations in muscle enzymes, evidence of focal muscle necrosis on ultrasound, and regions of coagulative necrosis in affected muscle biopsies. Horses typically have leukocytoclastic vasculitis in skin biopsies from edematous regions and high Streptococcus equi-M protein antibody titers. The pathophysiology of IPH involves a type 3 hypersensitivity reaction, triggered by a recent history of Streptococcus equi infection or vaccination. This reaction leads to vasculitis, edema, and extravasation of albumin. Horses with IPH have large amounts of Streptococcus equi-M protein immunoglobulin A immune complexes in the serum, and deposition of complement on these immune complexes in blood vessel walls leads to leukocytoclastic vasculitis, vascular occlusion, and tissue ischemia and infarction. Risk factors for developing high Streptococcus equi-M titers include being a quarter horse, intranasal strangles vaccination within the last 3 years, clinical signs of strangles within the last year, and older age. Therefore, it is important to test Streptococcus equi-M titers in horses with these risk factors prior to vaccinating against Streptococcus equi, and horses with titers greater than 1 to 3,200 should not be vaccinated. Treatment for IPH requires early diagnosis and aggressive intervention. Without prompt treatment, the fatality rate is high. High and prolonged doses of corticosteroids are necessary. An early reduction in the corticosteroid dose should be avoided. Appropriate antimicrobials, typically penicillin, should be administered if there is suspicion of concurrent Streptococcus equi infection. Horses with infarction of the gastrointestinal tract rarely survive. This concludes our exploration of Myosin Heavy Chain Myopathy and immune-mediated muscular disorders in horses. Thank you for joining me on this deep dive into the fascinating world of veterinary neurology. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.